Good morning and welcome to the spring seminar series for the Florida Department of Health Grand Rounds. March is Colorectal Awareness Month, and today we welcome Dr. Clement Guede and Dr. Kathy Mead from the Moffitt Cancer Center. A few things to know before we get started today. All phone lines are muted. Please enter the questions into the question box on the control panel. We will have time for Q&A at the end of the presentation. For your convenience, the slides from today's presentation may be downloaded. Please click the PDF file located under the Handouts tab on the control panel of your screen. For those that would like to receive nursing continuing education credits, please fill out the survey that will automatically pop up when the webinar concludes. Be sure to enter your correct license number. Today we will have Felicia Dickey introducing our speakers. Felicia?
Thank you, Robin. Good morning, everyone. At this time, it is my pleasure to introduce our presenters for today. Dr. Clement Guede is Senior Member of Health Outcomes and Behavior Division of Population Sciences at the Moffitt Cancer Center, the Professor of Oncologic Sciences at Morsani College of Medicine at the University of South Florida in Tampa, Florida. He serves as chair of the Florida Cancer Control and Research Advisory Council, CCRAB. CCRAB publishes and coordinates implementation and monitoring of the Florida Cancer Plan, years 2020 through 2025. Dr. Guede is a public health and health equity investigator whose research is primarily fueled by community engagement and community academic partnerships to develop, test, and implement behavioral interventions for prevention and early detection of colorectal and prostate cancers to eliminate cancer health disparities and improve quality of life. He also conducts research on minority participation in clinical trials and community participation in biobanking and research involving biospecimens. This research has been supported by grants from the American Cancer Society, National Institute of Health, National Cancer Institute, U.S. Department of Defense, State of Florida, Florida Blue Foundation, and other sources. He has published over 140 peer-reviewed articles in scholarly journals. Our next presenter will be Dr. Kathy Mead, who describes herself as a community-minded researcher. She is a national leader in the field of health disparities, community education, and health literacy, and interested in the role that culture and literacy play in the development and design of behavioral interventions. She was one of the first investigators to conduct studies whereby mismatches were identified between patients' reading levels and the reading levels of health information. Her current research spans cancer prevention to survivorship and seeks to bring information, services, and scientific advancements right back to the community in ways that are understandable, useful, and practical. This entails the use of community-based participatory methods that build sustained and trustworthy community partnerships for improved health. A notable outcome of her work is the creation of the Tampa Bay Community Cancer Network, a community academic network since 2005 that has informed community-driven studies such as the one you will hear about today for improving colorectal cancer screening uptake in Florida community clinics. It is my pleasure at this time to turn the presentation over to Drs. Guede and Mead.
Okay, thank you everyone. Kathy Mead here, and thank you Dr. Felicia Dickey for that lovely introduction. And it is a delight to be here, not only in person to a group of attendees, but also to other participants throughout the state of Florida. Dr. Guede and I are really delighted to talk about community cares, more fondly known as C-CARES, Colorectal Awareness, Research, Education, and Screening, a multi-level intervention to increase colorectal screening in our community clinics in the state of Florida. We also thank the Florida Department of Health and specifically the Bankhead Coley Research Program for the funding of this endeavor and for a variety of other studies that really helped inform and shape this particular project. So I'm going to move away for our audience that's in person as we try to move and advance our slides. Ernesto. Let's see. There we go. As you begin to look at this word cloud, the words that you see here are quite indicative of what our research represents. And as Clement and I talked about today's presentation, while we want to get to the research design and the numbers and the findings, it's important when you're conducting community-based participatory research to have an appreciation for all those steps leading up to the enrollment of patients. So I'm going to talk a bit about that and really set the stage for community-based participatory research and give you a sense of the intervention that was part of the actual study. And then Dr. Guede will take us through the actual design, the findings, and where we're going with the next steps with that. So when you think about our communities here in the state of Florida, they're diverse, they're multicultural, they're multilingual. And as you can see from the variety of pictures that span from the Panhandle down to Southern Florida, they bring their backgrounds, their customs, their values, their preferred language, all very important when you're creating and designing interventions that are trying to get out into the community. For those of you in public health, and I think a lot of the state of Florida employees are very interested in that, cancer prevention is really being re-emphasized. Recently at Moffitt Cancer Center, we had a visit from First Lady Dr. Jill Biden and our NCI Director, Dr. Ned Sharpless, who really put forth a renewed emphasis from the Cancer Moonshot to really reignite and reboot and resume screenings. We know that during COVID-19 pandemic, that screenings for some people were put to the side. It was hard to get appointments, we all know that. And now is the time to resume that. So for those of you that are in this space of interest in research, the opportunities will abound. So as we begin to look at our work, and specifically this study, and I believe the interest of so many here, let's talk about health disparities. We know that there is an unequal burden of cancer disparities, not only nationally, globally, but right here in the state of Florida and right here in our own neighborhoods. And to really begin tackling health disparities, there's really no single cause and there's no single solution. Therefore, we need to be very creative, we need to be very innovative, and we need to be very, very engaged with our community partners. Now, this particular schema, I think, really illustrates the problem that we've been trying to tackle. And that is what we call the discovery, development, disconnect. And if you look at the reference, this is by Harold Freeman, Dr. Harold Freeman, who interestingly is a breast cancer surgeon up in Harlem. And several decades ago, he noticed a very unacceptable cancer mortality from breast cancer among the women in the community. Many also associate Dr. Freeman as being kind of like the father of patient navigation, which, as you know, in the last couple decades has really launched. The point being is that here at the College of Public Health, the state of Florida, at Moffitt Cancer Center, we're well known for discoveries and scientific advancements. But if we can't, through our development, get those discoveries out to our community and deliver them, what benefit have we provided to our community members? And thus the importance of community-driven research. So today we're going to create research partnerships for health equity and better health. And so what we'd like to do is to showcase and summarize the development and design of our CCARES project as well, that addresses both initial and repeat colorectal screening using what we're calling the fit to colonoscopy model, fecal immunochemical test, which is mostly for average risk individuals. And at largest, okay. And so with that, the objectives are fourfold, and to highlight the importance of community development, community academic partnerships, which if we did not have forged those, we would not have been able to carry out this project. Community academic partnerships and the importance and how we created the Tampa Bay Community Cancer Network. And of course, the topic that's near and dear to my heart, the infusion of culture and health literacy into what we do in terms of the intervention. And then last but not least, to really highlight those lessons learned from community-based participatory research for improving its screening. So with that, I think we know that colorectal cancer is certainly quite important. It's the third most commonly diagnosed cancer, second leading cause of death. About 1 in 20 people will be diagnosed with colorectal cancer. And I think what we're seeing is that many individuals are being diagnosed younger. Hence, the guidelines have now shifted to 45 versus 50. I think in the last few years, we've heard about the death of Chadwick Boseman, other well-known people. If you're from Wisconsin, Green Bay Packers, Vince Lombardi, who died of colorectal cancer. And any of you that may remember way back, Audrey Hepburn, who really brought to light Eliza Doolittle in My Fair Lady. So the names are important because they're well known, but they also affect our neighbors and our friends. And on a personal note, my nephew's wife, 48 years old, just died last fall of advanced colorectal cancer. So it is hitting people at younger ages. And so the importance of screening is just so important. The good news is that colorectal cancer is preventable, treatable, and often very beatable. So now this next slide is the interactive portion of the talk. Which answer would you select? What percentage of deaths could be prevented with CRC screening? And so since we have an audience here in person, how many think A? Raise your hand. People can't see you, so don't worry. B, 47%. Okay, we got a couple takers. C, 60%. Got a few more takers on that. Okay, and then 85%. 60% is the correct answer. But the point is, it's really a beatable disease if detected early, and we bring it to people's awareness. So Tampa Bay Community Cancer Network is predicated upon a community academic model. So you might say, well, what is a community academic model? It's really where there is shared input, there's shared ideas among community members as well as academic members. And we have about 30 individuals from our community who make up TBCCN. Now, TBCCN was founded in 2005, and we were originally funded by the National Cancer Institute for 2 cycles. And I'm pleased to say that after funding ended, which is always a concern of us as researchers, our cancer center has sustained the TBCCN. It now has spun off into 4 working groups that relate to screening and biobanking, HIV and cancer, survivorship, and youth education. And I mentioned those 4 topics because those topics were wanted and needed by our community members. So when we started the TBCCN, and Dr. Guede has helped champion this effort as well, we pulled our people, community members together, and we decided to focus on colorectal cancer. So you might say, well, why? Well, at the time, there had been a great deal of focus on prostate and on breast cancer, and they wanted to focus on a cancer that was important to the state of Florida and their neighborhoods, affected both men and women. Now, while a number of the networks funded around the country focused on specific racial ethnic groups, the decision by our community partners was we wanted to focus on everybody, but specifically the medically underserved. So that really set the stage for a series of studies, which you'll hear about shortly from Dr. Guede, in the area of colorectal cancer screening. Several key factors and pillars really signify and relate to TBCCN, including culture and literacy, always striving for mutually beneficial research, ethical research designs, and appropriate methods. We soon, in talking to many of the program directors of our funding agencies, we couldn't just offer, this arm, no type of care or services. We needed to be equitable, and you'll hear about that. But also, I think what's important in our research is that we could reach racially, ethnically diverse population. and we also were sensitive to the language preference as well. While TBCCN started out mostly in the 3 counties that you see here, we've expanded more to 15 counties and soon to be 23 counties as well. Okay, we'll keep going forward here. Ernesto, I need a little help to move it forward. There we go. So there are 4 questions that really drive all of the studies that emerge from TBCCN, which are based upon partnerships. And these are questions that if you're embarking on any research or even any type of health education programs, is to begin to ask. 1, what are the community concerns? Now, sometimes the community may not know that it's a high priority, so perhaps you need to marry the data with what the community members are saying. Be very data driven, but also hear the stories from the community. Begin to think about how is the community going to be involved? Can they be involved in the design of the study? Involved in a community advisory group? I will say from our experience, not all community members really are that interested to be on the publication. They want to be on the story that gets out to the local newspaper, but they're more important in the design and the development of the intervention and the research. So discussion and dialogue, and that occurs by interacting with your community partners. I mean, obviously with COVID, we've been a little bit off because we haven't been as much able to go out to the community, though we've had virtual Zoom calls. But now, as we can see today, some of that is changing. We can get back out there. What do we plan to do? What are the methods? Often when we're stumped with recruitment strategies or how do we reach a population or how do we do something, if we bring the problem or the issue at hand, it's amazing how the answers are easily revealed when you engage community partners. So we develop and design with our partners, and most importantly, what are the outcomes? We don't like to see research sit on the shelf. And you'll see that our next endeavor is based upon implementation science, where we're trying to deliver and really sustain those evidence-based interventions at the community levels. And I think we've all been there as students. We completed our research. Maybe we do one publication, present to the stakeholders, but really think about what your line of research is going to be and how you can make it more longer lasting. So with that, let's see where we're going next. This is a pause where you can breathe until the slide comes. No. Okay, Ernesto may need to advance. Either that or we're stuck in time here. Yeah, we'll try pointing at everything in the room, right? And Robin's coming to save me. Okay, okay, we just moved a far distance. Okay, we'll go back. I think we're at CBPR. Yeah. Okay, we're at CBPR. All of you have heard of CBPR, raise your hand. Yes, yes, yes. Many of you. If not, here it goes. Community-based participatory research is an approach which often typically can bring together typically siloed stakeholders together to share their ideas, their collective wisdom, and their new approaches to solve problems. So there's our silos. We want to bring those silos together. So to bring the silos together requires engagement with an audience, and it also involves a lot of discussion. It provides what we call, if any of you are anthropologists, an emic perspective, kind of that insider viewpoint of, is this really practical? Is this really feasible? And it also strives for co-creation of knowledge, so that we're really co-learners in the whole process. It's not the academic center, they have a set of knowledge, but community partners also have an extremely important set of knowledge. Now, where does culture and literacy fit into this? I think our philosophy is that it's fundamental for effective communication to really advance health equity. But how so? Culture, as you may know, really refers to a socially constructed kind of this constellation of practices, ideas, competencies, or some people refer to it as a worldview, a perspective on life that informs people's everyday thinking and belief. At the end of the day, whenever you might go out to a health event, we all have to realize, or they come to a cancer center, people are coming from a neighborhood. Whether it be urban, whether it be rural, they come from a certain set of beliefs or operating paradigms within their family. And that's so important when we're planning our interventions. And so I encourage you to continue your readings. There's many available free resources from NIH on cultural frameworks. Now, obviously, this is really one of my most exciting topics I like to talk about. And I've been involved in health literacy for multiple decades. But when we started out in health literacy, a lot of the health literacy really reflected on the readability of materials and the readability of patients that was either assessed by like word lists and things like that. But it has moved from two definitions now in Healthy People 2030. The degree to which individuals have the ability to find, understand, and note and use has been added, information. But it has also been coupled with organizational health literacy, which is the degree to organizations such as Moffitt Cancer Center, University of South Florida, the state of Florida, enables individuals and groups to understand and use information. So think about what you do on a daily basis. How do you and your teams help to enable and facilitate that as well? Health literacy definitions have evolved over time, but what is clear is that we can't just focus on the individual. Equal attention must be given to the organizations, and multi-sectoral engagement is quite critical to the whole process. So how do we begin to infuse health literacy and culture in our everyday activities and interventions, such as we have with our colorectal cancer interventions? Well, one is get the real mindset. I'll tell you about that in just a moment. Be systematic, be iterative, always involve your users in the process. Conduct formative research. All of our research has been grounded on a great deal of focus groups, in-depth interviews, different types of pre-testing that is conducted along the way until we get to the point where we're actually going to start the study. So we have lots of built-in feedback loops that are important. We'll have our man climbing his stairs here. So get real, we coined this term a couple years ago of ensuring that information and interventions are one, relatable, engaging, actionable, and literacy friendly. And if you look at these materials here, these are the ones that we're utilizing in our colorectal cancer screening projects. And to give you another example, we've also incorporated theoretical constructs from the preventive health model. So just to give you an example of how we blueprint and we map these constructs out, one of the constructs from the PHM model is cancer worry. So based upon the formative findings that said people were afraid and fearful of knowing about a cancer diagnosis, perfectly normal, we then included that message in the material, both printed in terms of a photo novella as well as our videotape as well. And we actually had the provider reassuring patient and acknowledging that. From our literacy perspective, patients were somewhat unsure to how to use the information and to how to do that little fit test, which we'll show you in a minute. And so we showed people assembling the fit test, the components in the bathroom, the setting that they would collect it, and then the next scene, they're either mailing it or bringing it back to the clinic. And then just as a last example of the construct of social influence, our formative work revealed that provider suggestions, and this is holds true for other cancer screenings, is a very powerful motivator. So in our materials and our intervention, We had doctors make a very definitive recommendation. We also provided provider training and education as well. So this just gives you kind of a sample of our 2 sets of materials. The CD is put in like a sleeve in the back of the booklet. But I will tell you that when you saw the Spanish language materials, I want to bring up the notion of transcreation. Transcreation is not only translating, but culturally adapting the information. It would be easy to take the English version, send it to the translator, which many of us have access to, and then return it. But it may not get the cultural nuances that might resonate back to worldview of what really is quite strikingly important. So it's a practical and scientifically sensible way to develop an intervention for a new audience, which was, as our TBCCN partners reminded us, always a goal. Our very first study was only enrolling English language preferring individuals. And they said, okay, we'll go along with that, but no, you have to come back and you have to revisit a program for Latinos as well. And we did. And we again thank the Florida Department of Health because they also funded that from Bankhead Coley as well. Another method that we often use is learner verification, and this is just another pre-testing method that ensures the suitability of the materials, the intervention, and even to the point of, like, if you're developing these long, lengthy surveys or instruments, that you can get some feedback of if it's workable or not, or what wordings need to be adjusted. Okay, just to give you a couple examples as I'm kind of wrapping up my section here. So one of the elements of learner verification is comprehension. So as what you can see here is that we started out with our comprehension of trying to show where the colon was at in the gut. And as we moved through the second version, we did a call out so that people could see where a polyp might be developed, but people felt that that really still wasn't clear enough. So the final diagram shows a much more, kind of a circle calling attention to it. So this went through several iterations until people said, okay, I get it now, it's much more clear. Because sometimes we have pictures and diagrams of kind of free-floating bodies, but what am I supposed to hone in on? You as the developer need to be sure that it's clear, because what's clear to you and me is only what's clear to you and me, obviously. So I'll give you another example before and after. Again, as we talk to our community members, they like the concept of a photonovella, kind of a story instead of just having all this text. And so we kind of moved from something like this to what you commonly might see, in a photonovella and little call outs, and to make it engaging. And the other thing you can see is that we needed to create some headers so that it could cue the reader what was coming next and what that page was going to be about. So again, good health literacy principles. If you go to CDC, if you go to NIH, there are many clear communication practices. Agency for Healthcare Research and Quality has toolkits. So there is really a multitude of resources. And I think from the state of Florida, I think many of you probably are familiar with those as well. And then just to give you a sense of the element of attractiveness, often when we go and we pre-test that, we'll ask somebody and say, well, here's a booklet or something like that. What does it mean to you? Anything that bothers you about it? And so while this had a lot of engaging individuals, people felt that was a little blah. They wanted vibrant colors, and they really wanted the focus on the family for our Spanish language material. So that was the final version of that. So my last slide, of course, is our most popular health literacy tool, our little porta potty. So you might say, well, why do we have that? So it's very curious to think that this could be a really helpful teaching tool. These are like these $30 things you can buy. And we provided and outfitted all of the clinics in our study, not only with the materials, but also with this as a teaching tool. Maybe that made the difference, do you think? I don't know. But in any case, as you can see, you've got a kit, and it has tissue paper in it. It has a little tube. It has a red piece of paper that looks like a hazardous. But how do you dip it in and how much and all that? So this is a really helpful visual tool. And as what we've often said in our team meetings, when you go to health events, don't put it on the floor because the kids may think it's for something else, and you may have your sample and you may not even know it. But in any case, think creatively of what your tools would be. And so Clement and I decided that this is the cue for Clement's presentation is this particular potty. So Clement,
so here
come on up.
At the queue of the potty.
Okay.
And I think Dr. Mead is more excited about the potty than anything else about our research. You just saw a glimpse of that, but she's really quite animated about the importance of the potty as a health literacy teaching tool to walk the person through the components of the kit and make it easy for them to understand and know how to collect the sample. So I'm gonna switch gears a little bit and move into the research itself. And I've worked with, thank you. We go from short to taller. Okay. I've worked with the Department of Health in many capacities as the chair of CCRAB and other roles, and worked with Felicia Dickey, and I've presented to some groups, not this particular one, in the past when they were used to convene at USF. And it's always exciting to talk to a real world audience. So just by show of hands, how many of you are close to the point of care in your roles? And how many, show of hands, nurses and any providers? None. So this might be foreign territory for you there. Okay. There you go. And by the way, the age for colorectal cancer screening has now been lowered for average risk individuals, meaning you don't have a strong family history or symptoms and things of that make you increase risk, is now 45. Just by scanning this audience, you may be a little bit below, but be prepared to get into the topic and discuss it and do it for yourself as well as for your family members who are eligible. With that said, I might actually, does it work better the other way?
It does with the, yeah.
With the
Just advanced, yeah.
side? Well, it doesn't seem to want to work.
Oh, it's coming.
It's animation dilemma. Okay, so we have here a common measure that is used nationally and in your health departments or Florida Department of Health at your county level. And this is called the UDS, or the Uniform Data Standards, that tries to assess what proportion of patients who are eligible for a certain performance measure are actually meeting it. And what you see here is the measure for colorectal cancer. And what we did is we took for the whole entire country, and we have Florida there highlighted, showing that even though colorectal cancer screening rates nationally are at 69% or somewhere in that range, Florida is about 67, 69% as a whole, there are areas where we see disparities. And this is only one dimension of the disparities, in the sense that for Florida, the average within federally qualified health systems and other community clinics that report this is about 44% about now. But within each clinic, it may be even lower. So we have clinics that we're working with that are about 30-something%, and some clinics are over 50%. So there's a gradient of disparity, and it gets worse for some communities, as you will hear. So the good news is Florida is doing better than many states in the union. The bad news is we are nowhere near the national target of reaching 80%. We want every community to be at 80% of eligible individuals being up to date. The challenge with the modalities that we use, colonoscopies are expensive, inaccessible. You have to be insured and no deductibles, and many reasons why people can't get a colonoscopy, in addition to the fact that it's a scheduled procedure that many people are not very comfortable doing. So our strategy of fit to colonoscopy home stool test that is a high sensitivity and high specificity for the epidemiologist in the room, it's really been proven to say if it's going to be abnormal, it's most likely going to be cancer, and therefore it's helpful, or at least it's picking up something that needs to be investigated further. And when you have a FIT test come back abnormal, the next step is to get to a colonoscopy to allow for visualization and detect whatever abnormalities may be there. Oftentimes it's not cancer. It may be many other conditions of the colon and the lower GI that are causing hidden blood in your stool. So it's a very good test to get the next action done. So with that though, it's recommended to do year after year after year, which is a big challenge in these health systems because people have to be tracked, people have to be aware that they have to get it done. So the measures are challenged by the need to repeat this. Colonoscopy, on the other hand, once you do it, if you are clean, then you have a bigger window to be up to date. So we've done a series of studies that led up to the community care study. I'm going to zip through this very quickly for the interest of time. But the first study we did about 2010, began in 2008, was trying to ask the question about disparities affecting the African American community or the Black community in Tampa Bay. And one of our questions was, if people are not in the health system, can we get them interested in doing colorectal cancer screening with a FIT kit? And by the way, would they repeat it year after year? And so we conducted this study using a photonovela, Just As Been Shown, that was culturally developed. And our answers were, yes, we can excite people to get started on colorectal cancer using screening, and we got about 80% uptake. But the second answer, the answer to the second question, would they repeat even when we provide and mail it to them? These were people recruited in community settings, health fairs, churches, barber shops, and many other such cultural places. And our rates went from 80% initial, 12 months later, 12 to 15, 18 months later, it went down to about 55% and to 40-something% at 24 months. So that just really told us that, yeah, we have a challenge. And then we did the next study, which was the beginnings of these CARES studies that you heard about. And that study was saying, okay, we did a study in community settings and we can do it in health fairs and so on, but can we raise the rates in the federally qualified health systems, the Department of Health? So we did a study with a number of FQHCs and Pinellas County, or Florida Department of Health at Pinellas County, that clinic, main clinic. And we also found that we could increase screening rates, but this study didn't have a repeat component, but it had the same materials that you saw. And then we transcreated into Spanish language and did a small pilot in federally qualified health centers asking the same question. Spanish preferring population, can we increase screening rates initially? And we also found over 80%. So getting people started on screening is easy peasy. Everybody, 80% in our studies. But getting them to maintain was the challenge. So we did community cares in community clinics, federally qualified health centers around here, San Jose, Premier, and others in this area, to answer the question of repeat, initial and repeat when access is provided. And that's the study I'm gonna talk about more now. So here is the results that I've already told you. You see all the bars for those 3 area studies are at 80%, blowing all the benchmarks for the nation. But as I said, it falls apart when it comes to next year. And does it matter which FIT kit you use? It doesn't matter. In our research, we use the PolyMedCo type, one kind. The clinics use HemoSure. They have different abnormal rates, but it's the same idea of a high specificity, high sensitivity test. So the goals of the community cares were to really test these educational materials that you saw earlier in increasing screening rates. And at the time it was age 50. We now dropped it to 45 for the studies we are doing now. And then we also wanted to know what are the mechanisms by which these interventions work, so we can send those lessons downstream for future implementation. And it was a multi-level intervention, taking advantage of the fact that talking to patients is just one aspect of increasing screening rates. We need to work at the whole system level, where we engage patients in education, provide them access to kit, engage providers and other frontline care workers to remind people and facilitate access. And by the way, work with the health system to prioritize cancer screening and colorectal cancer screening and doing many different aspects. So it's a multi-level intervention. And we were focused mostly at the patient in the design, but we were tweaking things in the environment to help things work better. And the design is very complicated and the slide is not very easy to follow. Trust me when I tell you that the design was a classic randomized clinical trial design, where we have two arms and people at the individual levels who qualify are then randomly assigned to one condition or the other. The difference between these conditions was the fact that on the one hand, they all got the education material, access to the FIT screening, and they were generally left alone in terms of some of the assessments. They were assessed a couple of time points so we can learn more. On the other hand, we introduced the idea of, can we coach people who receive a FIT kit but don't return it? And we wanted to individually intervene with them to understand their barriers for not returning the kit. That's the coaching component, and then address those. And we thought, oh, this is easy, right? If you can reach me and tell me why I need to be screened, I have the kit in hand, it should all work very beautifully. I'll tell you in a minute how well it did not work. So our eligibility was classic. 50 age was the main thing, not up to date, not being average risk, no symptoms, no strong family history. And we collected a number of different instruments for theory and for understanding the mechanisms using tablets. And the study was fueled and driven by our study coordinators working in those clinics, primarily doing the labor of doing and enrolling and doing the coaching intervention, with an eye that we could then, if it works, employ health system people to actually do the work. And again, you see the tools we used, and this has already been covered. There were many questionnaires done at baseline when you went on the study at 12 months and at 24 months. So we can again characterize and describe things. Yeah, this is the hazard of doing it this way. So I'm not going to spend a lot of time. So this is sort of the picture of how the study was rolled out. At the top, you see the clinic locations, and we approached a lot of people. I think this works, maybe it doesn't work. As you see in that second layer here, we approached a lot of people to find a few people who were eligible. And you can go down and see how many ended up being enrolled and consented. And so there's a lot of labor involved, but because it was a funded study, we used the coordinators to do that. So successfully reached our target sample of 328 people that were randomized. And see here, here's the money slide, right? So the top line tells you what our projections were. We thought we could accrue a certain number of people a month and it would be done, if you look here, about midpoint of the graph in about a year and a half. The next line, the red line, tells you how we actually did our accrual rate. And that line is telling you that it's hard work. It wasn't as blockbusters as we projected. And obviously more boots on the ground will help. And again, this was coordinators. The third line, the lower line, green line, whatever color that is for you, shows us the FIT kit return rates as people are enrolled. And this is just only talking about the baseline, getting on the study 3 months later, looking at whether you did the kit or not. So if you are quick in math, you can do the calculation of 225 over 328 and get that proportion, but I'll tell you in a minute and see what our screening rates were. So these are some demographic. What is important to point out here is to show you that some were predominantly female, which is not a surprise. We've seen that in through all our other studies. We accrued a significant proportion of Hispanic or Latino individuals, in part because of the clinics we were working with, but that's a plus. It was very diverse. And majority of those, about equal number, born in US and born in other countries, and low income. We The next money slide. How did the study do? So if you look at the total patient is really talking about, you know, the accrued sample, and the fit kit return rates are shown here. Overall, when we combine both arms, our rate was 69%. So we reached sort of the national average, but we didn't reach the 80%. And we'll talk a little bit about that. And we found out that people who were who received the Spanish language material were more likely to be screened. They were at about 77%. So the language was very powerful for that subgroup of individuals, perhaps because they don't commonly receive materials in their language. But we also learned, like we have done in the past, that most people return their fit kits very early, within the first 30 days. And if you don't return it within 90 days, you're never going to return it. So that's giving us information of how we might adjust our future studies and begin to do that coaching intervention earlier than what we did in this study. So when you do these studies, you clearly will find abnormals. Again, when we look at the fit kit return, no difference between the two intervention arms, and we had about 46 abnormals, people whose test came back abnormal and needed to be navigated to a colonoscopy. We don't repeat the fit kit. They go straight to a colonoscopy. You can see it's hard work. It is so difficult to get people from an abnormal fit, which you think is a no-brainer, to people get lost, they don't answer their calls, they don't want to do it. So about half completed colonoscopies on time, about 5 flat out refused. Their healthcare providers could not get them to do it. And we are still working with about 8 of those. The 13 are people we really absolutely can no longer reach. So that is part of the challenge, linking people to care after an abnormal fit, and it's truly hard work, even when working with the clinics. I talked about the coaching. I can tell you it didn't work. And there are many reasons why we think it didn't work. There were 160 people enrolled, 61 enrolled in that arm that received coaching if you didn't do your fit kit. 60 of those needed to be coached because they didn't return the kit in the time frame window. And we were able to reach 36 and deliver the coaching. 10 out of the 36 completed a fit kit after the coaching. We would have wanted to see much higher percentage as opposed to a third. So why didn't the coaching work? We think it was probably delivered late. We waited until 90 days. Now that we know most people will return the kit within 30 days, so we need to move the coaching earlier so that we can access people while they are still thinking about their colonoscopy and their kit. They gave many reasons why they didn't do it, but we are using these lessons in the next studies. So what are some of our next steps? We are currently completing the annual follow-up. It's almost done actually for this study. And the study has just ended, and we'll be putting our final progress report, music to Bunny's ears. And we are working, getting publications. We have one manuscript under review and working, and most of this work is published. We are also currently implementing another study funded by the NIH that is looking at a similar design of, can we excite people to be screened initially? Can we follow them for a year and 2 years and see what happens? Except this one is using a real world design called implementation science, where it's no longer a controlled clinical trial. We are disseminating it in the clinical environment, and it's driven by the clinic personnel. And it uses a rollout design where one clinic goes on the intervention and the others are held. We learn some lessons and we roll it to the next clinics. So it's a much more pragmatic design that is intended to really embed this research into the clinic processes. We also use a champion in place of the coach, because we thought champion is, a good word, right? It's positive, energetic, and suggests that the clinic is excited to retain and sustain this. And the champion is going to do the coaching, and the champion is going to look in the health system to see if they can tweak anything, identify who hasn't returned the kit, and talk to providers and really make it as part and parcel of the fabric of the institution. And we hope that work will then be proved to be more successful at improving repeat screening. We are also working in more rural clinics, not the ones in the urban Tamba. So we're working in Highlands, Hardy, and Polk, DeSoto, with clinic organizations in those areas. So to be continued, and stay tuned about the results of that particular study. So ultimately, when colorectal cancer is an important topic in the community, it affects pretty much everyone, sometimes early. Therefore, we need to engage communities and community partners and stakeholders in order to boost these rates. This is a no-brainer in the sense that we have tests that work. They are more affordable than ever before, but we still have the challenge of disseminating that discovery delivery disconnect. So this work is trying to address some of that. So our research has been helpful in improving screening rates in clinics, but we are challenged. Our research has been helpful in making access available to populations that would otherwise go unscreened, but we have challenges in the sense that we need to repeat and maintain this effort year after year so that communities can benefit. With that said, I'm not sure how much time is. Can you tell, Kathy?
10 minutes.
10 minutes with, okay. So with that said, I rushed through this to give you a flavor. Hopefully you have questions. If you don't, I'll keep talking. So in order to prevent you from hearing and listening to me, please ask questions. We publish many reports, health literacy, community partnership, intervention outcomes. You can look that up. There was many thanks to many people. It takes a team to do this work, particularly the study coordinators that went to these clinics were working as part and parcel of the clinics and were really engaged in trying to get the whole system excited about colorectal cancer screening. I know Felicia and the Department of Health have worked with some of these clinics. It's a lot of data collection, but it's a beautiful thing when you learn how you could improve the processes so we can apply it going forward. So our final goal is to do this statewide with bigger funding and have a great impact of addressing both disparities and increased utilization of a modality that we know is efficacious or works, so we can benefit all of Florida. With that, we will take questions. So yes, in the back.
Well, this is kind of what you've been doing in the outreach and the literacy and all of that. That's really great to hear that. I'm a nurse, and my experience has been, it's hard to get people to go ahead and.
That's okay. Yeah. You're good now.
Okay, it's hard to get people to sign up and to go for the colonoscopy. Okay, and I guess my question is there anything coming in the future that might make it easier? Right now, it takes 2 days out of a person's life, and everybody that you talk to, if they just go on about how, you know, they're confined to the bathrooms for 24 hours type things, and it's just people don't want to give the time up. It's just, I don't know.
No, it's a fantastic question, or in the sense that it really is. It's a simple prescription, right? I want you to get a colonoscopy because you are in the screening age. Oh yeah, right. Straightforward message. But a colonoscopy is very involved, and for most people, it's scary. It's not accessible. It's not practical. Many men think it's a violation of their privacy. They don't understand how we can go places, and yet we still do that procedure to find colon cancer. So there are many other procedures that could be done as an alternative. The stool test, yes, but all roads lead to a colonoscopy.
Right.
When something is abnormal, you know, CT colonography, you can do a pill camera, you can do all this stuff, but it still requires a colonoscopy when something abnormal is found.
But it's the prep that.
Yeah.
that-
So what
That's a very-
you are right. The
Yeah.
prep, but the prep has improved. it's no longer buckets and buckets of liquid you have to take. It's a 64 ounce of Gatorade with some other.
Different flavors.
Yeah, exactly. So if you change the way you look at it, things have improved. This is no longer your grandmother, grandfather's procedure. It is our most improved is the prep. But I've done it, the colonoscopy. You do spend time. You get very intimate with your toilet. Pretty much, the party. So the approach for people who have who don't have insurance, uninsured kind of access, rather than wait until a colonoscopy is accessible, this is a good option.
Yeah.
And it can save in this resource limited environment, can save a lot on the unnecessary, unaccessible colonoscopies. But your point is very well. Individuals have many reasons why they don't want to do a colonoscopy, even when they are insured.
And usually a lot of people will tell you it wasn't half as bad as they expected.
Yes.
They actually got through the procedure.
Plus, you have a fantastic sleep. They no longer give general anesthesia.
Right.
They give all these medicines that are really beautiful sleep.
But the
20
prep just
minutes.
takes-
Yeah, 20 minutes, they're done.
So we do have, we do have another question online. What is your opinion on the future impact of biomarker testing to improve
Yeah.
health promotion behaviors regarding colorectal
Yeah,
cancer?
so that was the second part, I think, of your question, going to, are there other better ways? There are studies that are looking at the use of blood tests, looking for DNA and other changes within your DNA. Even the stool DNA is one such a technology. And we are also working with a couple of, I'm gonna say, industry partners to try and look at the question, if we give individuals choices of either the stool test, the colonoscopy, or a blood test, what would they prefer? What would produce more compliance? So these studies are just now rolling out, but at the end of the day, I haven't heard of a future procedure that could replace a colonoscopy. So that's the big message. We just need to get comfortable with the idea that it's one procedure you have to done. It's the most thorough. When you can access it, you should do it. When you can't access a colonoscopy, get the alternatives. They work just as well until you're able to get to your colonoscopy. But yes, biomarkers have a future role. They just haven't finished the research yet.
We have time for one more question on the webinar. The next question is, abnormal FIT tests will result in a recommendation for a colonoscopy.
Yeah.
How are these paid for if the patient is uninsured or underinsured?
Yes.
A high deductible or copay? Does this contribute to your?
Absolutely. That's part of the dilemma. But fortunately, in the state of Florida, we don't have like the breast and cervical cancer program that funds things, the initial or the follow-up screening. For colorectal cancer, there is no such a program, or at least it's very limited. So what we've done at the Moffitt Cancer Center is we've used all available options. We screen people with an abnormal FIT to eligibility for Medicaid, and patient assistance programs in the community. There are many GIs, gastroenterologists who donate a procedure. And at the Moffitt Cancer Center, every person who participates in our studies who has no access can be evaluated and navigated to access a colonoscopy. So the ones that went down is not because we couldn't cover them with patient assistance. It's not that they refused or couldn't find them, essentially. The clinics lost them. We lost them. So at the end of the day, not a single person who needed a colonoscopy, wanted one, did not get it because of insurance. We have strong patient assistance programs at the cancer center, including foundation funds that were used to.
But at the end of the day, if you're going down this line of research or any other cancer screenings, the follow-up must be in place. And as a grant reviewer, they should be looking for it as well.
Yes, yes. Unfortunately, the research funds generally don't pay for NIH, for example, for colonoscopies in part because they are expensive, but they also don't fund for things that should be paid for by other programs such as HESA. So it is a thought process that we sit down with the clinic partners and map out what happens if a person is abnormal. Even in the community study, when I went to a church, the pastor would ask, what happens if there's an abnormal? because all it does is take one person who not managed correctly to create community negative attitude. So we work very hard to make sure everybody has access, and that's good news. Thank you so much.
Conclude the
you have one?
webinar, and then
Okay.
we'll continue. Okay, this will conclude the virtual part of our webinar today. Thank you all for your attendance. Please be sure to check the Florida Department of Health Grand Rounds website for upcoming registration and announcements. Special thank you to our presenters today, Dr. Mead and Dr. Guede. Thank you and have a great day.